Good afternoon, everyone, and welcome to today's webinar on strengthening health governance, fostering collaboration, and ensuring accountability. My name is Jemchang Fabong, the Health Practice Lead at Nextier, and I'm honored to moderate this critical discussion. We are pleased to have two distinguished panelists joining us, Dr. Gafar Alawode and Dr. Abubakar Kurfi, each offering valuable insight and experience in health system strengthening. To our participants, thank you for taking your time, despite your other equally busy schedules, to engage in today's dialogue. Today's session will examine how effective governance, stakeholders' collaboration, and accountability can transform healthcare delivery. We encourage you to engage actively through our chat and question and answer features. In pursuit of equitable and high-quality healthcare, effective governance forms the cornerstone of transformation. It fosters accountability, guarantees transparency, and builds citizenship trust in the system. When governance thrives, policies are not just drafted, they are executed with integrity and purpose. Collaboration amongst the government, providers, civil society, the organized private sector, and communities becomes seamless, enabling a united response to urgent healthcare challenges. Strong frameworks promote ethical service delivery and responsible resource management. They empower communities to voice their needs and influence solutions. Such collaboration fuels innovation, responsiveness, and resilience. Health systems develop not just by accident, but through deliberate and inclusive leadership. This is essential for unlocking universal health coverage in Nigeria and beyond. Just last month, the WHO printed a report, and Nigeria has one of the highest maternal mortality rate ratios in the world, with a large number of maternal deaths being recorded annually. The maternal mortality ratio in Nigeria is reported to be 1,047 deaths per 100,000 live births. And this means that for every 100,000 live births, 1,047 women die from pregnancy-related complications. And Nigeria accounts for a significant portion of these global deaths, with some reports stating that over a quarter of these deaths is reported in Nigeria. Nigeria is ranked with Chad, Central African Republic, South Sudan, and Afghanistan in that order. Nextier, a multidisciplinary advisory firm, is dedicated to solving some of these complex developmental challenges. Our mission is to create the society we aspire to live in. We employ evidence-based research to develop knowledge and skills that advance our societal progress. At Nextier Health Practice, we bridge the gap and bring stakeholders together and apply global best practices to design and implement innovative, contextually relevant solutions that address contemporary health challenges in Africa. Our international health professionals offer expertise in health system strengthening, health promotion, health communication, healthcare financing, primary healthcare, governance, health systems research, and human resources for health. Today is one of the Nextier Universal Health Coverage Dialogue series that is being held bi-monthly, and it's a public policy platform that gathers stakeholders to discuss the critical issues towards attaining universal health coverage in Nigeria. I want to welcome all participants who have taken the time to join this dialogue today. With me is Dr. Gafar Alawode and Dr. Abubakar Kurfi. Dr. Gafar Alawode had led several donor-funded health system strengthening projects across senior level in Nigeria and other developing countries, notably Liberia and Uganda. He served as a country manager for Liverpool Associates in Tropical Health, program manager for the Global Fund Round 8 Malaria Project, stepped in lead for the DFID funded partnership for transforming health system Path 2. Chief of Party for the USAID-funded Health Finance and Governance Project, and Country Director for Health Policy Plus. Gafar designed and collaborated with other stakeholders to introduce universal health coverage innovations, such as the Legislative Network for Universal Health Coverage and the Nigerian Universal Health Coverage Forum. He was appointed to the core group for the Health Financing Resilience Community of Practice by the World Bank. He led a team of experts in preparing the policy passion, preparing paper advising 54 Commonwealth Ministers of Health on effective aid utilization and domestic resource mobilization for health. He served as the principal investigator for Nigeria's policy analysis of health taxes and the policy analysis of local government area autonomy and in implications for primary healthcare delivery. Dr. Gafar is currently the Chief Executive Officer of the Development Governance International Consult. He earned a master's degree in tropical medicine from Liverpool School of Tropical Medicine after obtaining his first degree in medicine and surgery from the University of Ilorin, Nigeria. He also completed executive courses in health system management at Harvard School of Public Health. He's a fellow of the UK Faculty of Public Health of the Royal College of Physicians and a fellow of the Academy of Public Health. Additionally, Dr. Gafar is a chief. He holds the traditional title of Are Boni of Ijagola. Dr. Abubakar Kurfi is a well-informed and accomplished physician with a wealth of experience in leadership and governance in the health sector. He obtained his first degree in medicine and surgery from Ahmadu Bello University, Zaria. He also has a master's degree in public health and an MBA in international healthcare management from the Frankfurt School of Finance and Management. Dr. Kurfi is the planning, research, statistics, and director at the Nigerian Health Insurance Authority. Dr. Kurfi coordinates and drives strategic and operational planning and policy formulation in the NHIA to promote universal health coverage in Nigeria. Additionally, Dr. Kurfi oversees monitoring and evaluation, risk management, and health and social science research within the NHIA, focusing on strengthening the health financing system to enhance functioning of the health systems towards attaining universal health coverage in Nigeria. Let's begin with a brief opening remarks from the panelists before delving into the discussion proper. Dr. Gafar.
Good afternoon, Dr. Fabong. Good afternoon to our participants. Thanks to you and the Nextier team for inviting me to be part of this very, very important conversation, as governance is very, very central to whatever we do in the health system. We hope to contributing our experience. At the end of the day, we should be able to have some important takeaways that we can use to reform our health system. Thank you very much.
Thank you, Dr. Gafar. Dr. Kurfi.
Thank you very much, Dr. Fabong, and good afternoon to all the participants here present. I look forward to a very insightful discussion on how we can collectively discuss towards the attainment of universal health coverage in Nigeria. It's a pleasure to be here.
Thank you, Dr. Kurfi. So today we'll be discussing strengthening health governance, fostering collaboration, and strengthening accountability. Governance could mean anything to anyone. When we say governance, Dr. Gafar, what exactly are we talking about when we say governance?
Okay, thank you very much. Like you rightly mentioned, governance actually means different things to different people. But irrespective of how you define governance, some important pillars are very, very critical. And those elements coming together, they are very, very important in shaping the entire health system. And don't forget, governance is not only applicable to health, it's applicable to every system generally, whether in private or public sector. So when it comes to what are we talking about when we say governance? One important element of governance is around stewardship in terms of how do we provide direction, oversight. So I call it stewardship and leadership. I think that is a very, very important first element of a governance. Number two element is policy strategy. We got things that actually identify what is the direction to go, what's our aspiration, what's our target. Everything is well articulated in terms of direction of travel, what I call policy and strategy. Another important element of governance is an institution in terms of its arrangement and capacity. Like, for example, if we are talking about public sector, what ministry, department, and agencies, and what is their capacity, and what's their relationship with other, actors. So, institutional arrangements in terms of, for example, in the ministry, do you have a dedicated unit or department that is focusing on one aspect of our work? And what's the arrangement for bringing people together, and what is the capacity, which is a very, very important element. So another important element of governance is no ministry, department, or agency or area of work operate in isolation. So you have to work with different aspects, and I guess this is clearly highlighted in the caption for this webinar. So what is the mechanism for bringing different ministry and different ministry, agency, and departments, and the private sector and civil society to come together to discuss? I think the issue of a coordination or collaboration, which I must confess is one of the most difficult things to do in the health sector. And probably because we are not wired from ab initio to work with other effectively. But of course, we have to look at those that have done its work. Another important element is the issue of accountability, which is about holding people, institutions accountable for what they are supposed for their mandates and the resources given to them. And lastly, something which is a relatively new discourse in the health space is the political economy, which is about the influence and interest of actors and institutions, and how do they affect policy design and implementation and resource management. So all these 6 elements or 7 elements or thereabouts come together are the most important features of our governance. And all of them should work together. And don't let me forget, a very good governance environment use evidence or information for all the elements that I've mentioned. So evidence-based stewardship, evidence-based policy, evidence-based institutional rearrangement, accountability, and everything. So all these put together are the very, very important elements of our governance, and all these work together to drive other building block, whether we are talking about financing, whether we're talking about commodity, human resources management, and service delivery to achieve the desired goal. Let me pause here for now.
Thank you, Dr. Gafar. I'm still coming back to you. A moment ago, I said Nigeria has a very, very disturbing maternal mortality ratio of 1,047 per 100,000 live births. And of course, this is an extremely poor maternal health outcome. We rank in the top 5 alongside Afghanistan, South Sudan, Central African Republic, and Chad. Now, Dr. Gafar, how does weak health governance directly contribute to these high maternal mortality rates in Nigeria?
Okay, thank you very much. So to start with, let me create a more scary scenario in terms of maternal health. So if you look at the reports, WHO and UN monitoring group reports, they actually concluded that Nigeria has the highest number of maternal deaths. And Nigeria contributes 28% of all maternal deaths globally actually happen in Nigeria. So one of the reasons why we are here is looking at what happened after that report was released. You will discover that the entire space was silent. And then in other climes, that is even bad enough for us to quickly raise the accountability bar, to go to the street, to go to the National Assembly, and for all of us to voice out in terms of how do we raise the accountability bar for it. But unfortunately, we didn't see much response from the citizenry. What does that tell you about the accountability process in Nigeria? You understand? So accountability is a very, very big issue, and it is not only accountability as well. Another problem, which is the issue of coordination and collaboration. Don't forget that when it comes to impact level in terms of maternal death, is not only the business of the health sector. No matter how, if you see what we have achieved in the health sector actually make progress in terms of output and outcome to some extent. We have more people attending antenatal, more people delivering health facility. But if we are not able to get the other side, other parts, other stakeholders to do their bit, we are not going to make progress. So there's a problem of coordination and intersectoral collaboration. I was very excited when they turned the Ministry of Health into the Ministry of Health and Social Welfare, which means the ministry now has the mandate to work with other social sector and other sector alike to be able to address some of those issues. Policy is never our problem. We have policy documents here and there. But of course, the lead in terms of leadership, when I say leadership now, I'm not talking about hierarchical leadership in terms of who is the head, who is this. But all of us deploying behavioral leadership, all of us at our various levels, whether citizen, whether government and everything. Then again, the issue of governance, how it applies to the building block, how it affects maternal health. There's, for example, if you look at the issue of human resources for health, we just published a paper on optimizing human resources for health in Nigeria. There's a huge governance problem when it comes to managing the workforce in Nigeria. In most cases, there's a huge problem of absenteeism, ghost workers, which shows that somebody is not actually analyzing the data on the workforce and see how much are we spending on the workforce, what is this money buying, how can we improve on it and everything. So all the facets of governance that we've talked about, all of them have implication for these the result that we are getting that now propelled Nigeria to the country that has the highest maternal health. So every facet of the governance we talk about, there are issues there that we really need to address to be able to get to this impact level. Over.
Thank you, Dr. Gafar. Dr. Abubakar Kurfi, the 2014 National Health Act gave rise to a possibility that there would be an improvement in the trajectory of health care delivery in Nigeria. And in 2022, the NHIS transformed into the NHIA, which is an authority. And a key takeaway for us is the mandatory form of health insurance in Nigeria. Now, we've been discussing this disturbing thing called maternal mortality. And of course, it's something we shouldn't slip. How can the NHIA and the state social health insurance schemes be restructured to make this a priority and fund maternal and child health services more effectively in Nigeria?
So thank you very much, Dr. Fabong. Once more, good afternoon. And I think it's actually, let me first of all express also my sadness that we're starting with these very disturbing statistics, right? Despite all the enormous investments in the health sector, we're still seeing this very poor outcomes. This goes to show, of course, that the need for us to really rediscuss the issue of governance as far as healthcare is concerned. Before I move to the question you asked, I just want to flag some very important issues, which is the role of governance in terms of the issue of equity and social justice. And I think these are things that really we tend to overlook when we are discussing the health sector. One, I think equity is critical, that we deliberately, target those that need those services. Those mortality figures that you mentioned are happening at the most vulnerable points in our community. And so every intervention that we're doing should be targeted at addressing those particular class of people. Now, the issue of social justice is also very important. I think how our resources are distributed or redistributed, in terms of really those that are actually marginalized in the society. Good governance in the health system should be deliberate at addressing these two critical points. I'm laying this foundation because this is central to health insurance delivery, which I'm going to discuss. So the NHIA Act that we just mentioned has has given birth to the National Health Insurance Authority, which is supposed to be with the regulator, the integrator, as well as the promoter of health insurance in the country. The Act also empowers the NHIA to ensure that mandatory health insurance is a reality in Nigeria. Now, I would not say, well, yeah, back to your question where you said, how do we restructure the NHI or the state health social health insurance? I would not say restructure, rather I would say reform. So how do we reform what we do so that we can achieve the overall goals and objectives of the health system that we're discussing, right? So first of all, I think we need to be deliberate about expanding coverage. So for every single thing that we do, the focus should be on bringing more people into the health insurance net. And this we need to do by ensuring that we make health insurance the preferred mechanism of financing healthcare. That deliberate efforts need to be made both at the policy level, at both national and subnational level. The second thing is that we need to also be focused on quality of care. So it's one thing for you to provide health insurance, another for you to provide, let that health insurance buy you quality healthcare. And in this intersection, the marriage between the demand and the supply side of healthcare is very critical. So you can cover somebody with health insurance, for example, but if you go to the facility, will the services be available? And then here the role of other stakeholders like the Primary Healthcare Development Agency that is supposed to ensure that the PSC centers, for example, are working, comes into play. The role of the FMOH that's supposed to ensure that those things are available at the secondary and tertiary level also comes into play. So this is an important intersection that we need to discuss. And the next is to also deliberately focus on equity. Target those that really are most vulnerable in the society: children under 5, pregnant women, people who are extremely poor, and then of course the disabled, and people who are chronically or acutely ill, and this illness can tilt them into catastrophic health spending. And then of course there is an overlooked concept really that we need to flag, and this I attribute actually to the deliberate effort to ensure that the health insurance market is made efficient, right? Efficiency of the health insurance is very, very important. So by efficiency here, I mean not only in terms of value for money, but in terms of also stability and liquidity. So the health insurance stakeholders, health insurance is a risk. So if you are going into health insurance, there must be mechanisms to ensure that the risk you are taking, you can be able to financially sustainable. And the NHI is doing a lot working with all the various stakeholders to ensure that we achieve this. There are other enablers, of course, to this, which is data and technology, community, citizen-driven engagement, and of course, the organizational capacity and culture of all the systems and in place. So these are what we call the strategic direction of the NHIA, and by extension, the health insurance ecosystem. And I want to give credits to the DG of the NHIA, Dr. Kelechi Ohiri, for bringing this concept into being. And this is what is transforming the way health insurance is being run collectively in the country. So we say we want to see a reform that is deliberately targeted at achieving these 7 core things to ensure that we achieve universal health coverage. Thank you.
Thank you, Dr. Kurfi. So the takeaway for me is strategic purchasing for maternal health is really, really important if we have to tackle that disturbing trend. Dr. Gafar, we just dropped off from improving strategic purchasing and making the benefit package robust for the MNCH component to tackle that. What structural reforms in health governance are necessary to ensure this equitable access to quality healthcare across all regions in Nigeria? Can you do justice to that, please?
Okay, thank you very much. Well, we are looking at what are the key structural reforms that are necessary to be able to achieve improvement in the quality of care. So I guess we are looking at the structural changes within the context of governance. I think it is Very, very important. I think to start with, in all what we do, I think it is very, very important to be data driven. So even when we are talking about the quality of care, so what is the baseline? What do we mean by quality of care? What are we tracking? Who is tracking it? And at different levels, who is using this information for decision making? I think it's a very, very critical thing. There are a lot of instances where even when we have the data that is of good quality, like for example, even the NDHS data and all those stuff that is readily available, do we actually use them? So I think the starting point is we should have data and we use that data for decision. Let me give you a practical example of where use of data has been very, very useful. So we did that one analysis and we discovered in Sokoto State when they did the analysis of their workforce, and they discovered that the bulk of the workforce are actually non-clinical staff, constituting more than 80 to 90% of the workforce, while those that are supposed to be attending to patients at the front line are actually not there. What did they do? They used that information and to create a cadre conversion system. That's okay. Those existing workforce that we have that are not clinical, let's convert them. So let us be using that. So to start with, at all levels, we must be able to create the culture of using data for decision making. Using data for accountability is very, very key. Another aspect is that the resources that we are spending on health, because in health sector, we clamor for, oh, we need more money, we need more resources, which is true. It's extremely true. But at the same time, how can we do more with the existing resources that we have? Governance comes in because it's a leadership thing. It's a stewardship thing to be able to say, wait a minute, the way we are spending this money is better to get results out of it. So we have to look at how we're able to build institutional capacity to be able to analyze and take decision and monitor very well. So in the area of management, because we did a work around, we call it facility and financial management capacity building. We did it in FCT with using MPACD data. And then, of course, with fund from USAID, we're able to assess the capacity of primary health care, a capacity of health insurance institution. There's a huge gap in the managerial capacity of our health managers. That is the truth. Because central to issue of governance is management, ability to manage. Let me give you an instance. There are some state primary care board that did not have like a management meeting for like 8 months. Nobody knew what was happening. They were not sitting down to even discuss the plan and everything. That is very, very central. And it's not only about the level of the board, even the level of the facility as well, the managerial capacity. So, for example, who are the managers at the health facility? They are nurses, they are chiefs, who had their good, in some cases, good medical training, but never had any training in management. So, and these are the people that are saddled with responsibility of taking a decision in terms of planning, the little resources they have, and all those stuff. So we have to look at critically what is the managerial capacity of our health managers at all levels, from the front line to the primary care board, even to the national level, to make simple decisions in terms of, okay, we saw the data in terms of quality of care. Take, for instance, one of the important data around quality of care is to be able to see at the primary care level, for example, is to look at, okay, what is the proportion of facility delivery that results into postpartum hemorrhage? Because that's an important indicator of quality of care at that level. An ability to be able to say at the PAC level that, okay, probably we don't have to see, probably this and that, health workers are now trained, and they, okay, with little resources that we have, let's use that resources to be able to manage. So improving the managerial capacity, we often overlook it. But at the same time, it's not an automatic thing that when people have Nigeria capacity, they will just be doing things in favor of the system. Then again, Kurfi said something which I want to build on. You see, the business of universal health coverage is a business of equity, right? But it's not automatic that because I find myself in universal health coverage space, I align to the concept of equity. So that's what they call social value. We need reorientation in terms of social values at times. So I might be, oh, I'm managing a project which is on universal coverage. Do I subscribe to the value of equity and accountability? I think we have to re-examine all hurdles. And one other thing is that how do we leverage technology as much as possible? We have seen technology helping our governance in various ways. Let me give you an example. In Gombe State, they have introduced biometric attendance tracking, which is linked to the payroll. So, because one of the sources of corruption in the health workforce is absenteeism. So, use of technology as well, it has helped, and it is linked to the payroll. So, if I don't come, it automatically is deducted from my pay. And again, why that is possible, because later on I mentioned the issue of political economy, is because the governor himself is actually interested in cost saving, and then he provided the backing and the resources as well. I think those are some of those elements along the parameters of building blocks of governance that I mentioned earlier on that we need to tweak. Of course, there are others that others can contribute over.
Dr. Kurfi, you are the data man. And of course, Dr. Gafar said something, but most of this data is not reported in real time. And of course, we have had it very difficult in this country to have some form of a platform to collectively harmonize data. So I want you to shed more light on how data governance and health information systems gaps affect Nigeria's health outcome and our policy decision.
Okay, thank you very much, Dr. Fabong. So I want to start by giving a practical example. I was moderating a workshop, I think last 2 weeks, somewhere, I think in Lagos, and I asked this question. Somebody asked me, what is the coverage, what is the population, what is the number coverage of Nigerians who cover with health insurance? And I asked this question, I said, before I answer the question, I want to ask everybody in this room, what is the population of Nigeria? And I think there were 30-something participants, and I got 30-something different answers. So the denominator is already a problem, right? And building any percentage on that denominator is already problematic. Now, why I brought this in is because of the issue of reliability of data. It's very critical we understand that unless we get quality data, we will not be able to make any meaningful decision making. And this goes to affect every facet of the healthcare service delivery in the country. Before I just wanted to just give some little examples. The NHI is driving and implementing some very important community-driven interventions. For example, the Basic Healthcare Provision Fund. The Basic Healthcare Provision Fund is supposed to be a fund, it's a program that is supposed to provide health insurance for those who are extremely vulnerable in the society. What is the actual number of vulnerable Nigerians in the country? How many of these people are actually far, far below the poverty line that you target? So this kind of absence of this kind of data limits your capability to target and get those people who actually need those services. I also want to give another program that the NHI has recently rolled out, the CMONG program, Comprehensive Emergency Maternal and Child Health Program, which will provide free cesarean section for women who are vulnerable. The essence is to ensure that we save their lives and also ensure that these people are enrolled into health insurance afterward. Now, when you at the point of care, how do you know that this woman is vulnerable? What data elements guide you? To say that this person is vulnerable, this person is not vulnerable, right? And of course, there are other very important programs. So why I'm trying to bring this is that community governance at the community level is critical. And we want the community structures to play a role in awareness creation, to play a role in ensuring that they serve as champions of these programs and they create demand. And they also serve as actually accountability watchdogs. Because it's only when community level systems are in place that we can talk of quality information coming to the up, for decision making. Platforms are one thing, technology is one thing, but the systems and the processes must be put in place for us to actually harness the power of technology. That's the point I'm trying to drive at. So and people who know me in the office, when you come to tell me that I want to give you a dashboard, I say dashboard to dashboard what? I think it is the what that I am more interested in. Let me have those systems in place that will ensure that garbage is not put in and garbage does not come out. So that is number one. And that's where I think deliberate efforts need to be made to ensure that we put in systems for very good reporting, very good tracking, and very good harnessing of data for decision making, as mentioned by Dr. Gafar. And the absence of this system has actually affected all aspects of service delivery in the country. And the failure of what I call the failure of handshake between the various actors has also contributed to this. If you go to a healthcare facility, you see partners have their reporting tools. The NPSCDA will have its own. There's NHMIS at the. So we are overflogging a system that is already overstretched in terms of manpower and the rest, with too many tools for reporting data and the rest. And this also complicates the whole problem. So I would say the absence of data has actually really, really inhibited the progress of this country towards attainment of universal health coverage. Thank you.
Okay, still on the matter, Dr. Kurfi, as you were discussing, I was trying to note down something. You brought in the question of the Basic Healthcare Provision Fund. Yeah. And of course, it's one thing that those resources were adequately budgeted for. And beyond the budgeting of these resources, they were released. And these resources were equally distributed to the 36 states and the FCT, so long as they have fulfilled the basic criteria to have the gateways for this. But of course, you said something about citizenship, trust and oversight. And of course, the audit of the BHCPF 1.0 wasn't too good. So what role does accountability play in reducing health systems leakages and ensuring efficient use of public health resources in Nigeria?
So I would say, first of all, I would say this is my own personal opinion. I would say the BHCPF and similar interventions like this are one of the greatest public health interventions ever made by this government, by governments in Nigeria, because it's one program that has the capacity of transferring resources to the PHCs, and that's where most of the morbidity and mortality is taking place. Now, for accountability, what I want to say is that community level structures play a very critical role, in shaping the entire discussions for Basic Healthcare Provision Fund. And I want to see I would love to see community level engagement in area, for example, for awareness creation. People have been enrolled into the BHCPF. They may not even be aware that they are enrolled. So let people be aware that they are enrolled. Let community level accountability structures also play a role in demand creation. Empower people to demand not only for healthcare, but for quality healthcare. I want to see community level structures serving as accountability champions for complaints, for example, of enrollees, champions for quality of care, but also champions for accountability. Let funds tracking, funds management, be a concern for community level structures. That is the ambition, that is the thinking, that's what we want to see, because that's the only way an effective program like the Basic Healthcare Provision Fund can be made sustainable, and efficient. Thank you, Dr. Fabong.
That's beautiful, Dr. Kurfi. It's good to do budget tracking and of course to as well bring in some form of independent auditing with massive and robust community participation. Dr. Gafar, with shared accountability is largely responsible for integrated service delivery and resource pooling for broader health and social outcomes. And you are you are an all-rounder. For instance, you have worked with development partners. You are a private sector man, and then you have had some touch with both local and international organizations. So how can a public-private partnership, interministerial and multi-sectoral collaboration, for instance, education, women affairs, finance, infrastructure, social protection, be leveraged to improve health indices and accelerate the progress towards attaining universal health coverage in Nigeria? Thank you.
Okay, again, thank you very much. Probably before I go to the question around multi-sectoral collaboration, PPP, let me say one or two things around citizen engagement. I corroborate Kurfi's point about the centrality of involving the citizen. But we have to take note of, so what have we learned over time in terms of citizen engagement? What works, what doesn't? I think we have a practical example where we have put community structure in place, some of our projects, and we've seen clear results between the cohort of beneficiaries of one health insurance or scheme or the other. Between one cohort where we have strong community system and the others that did not have. And we see better facility utilization. We see better way of conflict management and improved quality of care where we have stronger community engagement. But is it all community engagement that translates to results? The answer is no. I think the most important element is to really identify people that are committed and are serious about doing this, and to be dynamic in terms of membership of the community structure that we have. So based on performance, if you are interested, if you are showing results, we'll keep you. If you don't, we don't keep you. Unfortunately, the structure from the MPAC, they say, oh, the community structure must be this, must be that, must be that. But at the same time, we are not very deliberate in terms of looking at behavioral leadership, in terms of when we put these people together, are they working or not? Because in some cases, the community structure are even the corporates, colluding with the health workers to steal money. We have seen that. So we have to be very careful when we are saying community structure. What are the main elements that make community structure to be very effective? Like I said, one, we have to be intentional about their selection. These are people that have a credibility, track record, and serious. And number two, we have to look at flexibility in terms of membership. If you are not performing, you can go. Then thirdly, we have to look at what are the context appropriate incentives to be provided to these community members. Because we always say volunteer, but is there anything that they can benefit? Like, for example, where we put community structure in place, one of the benefits of for them is that they themselves have health insurance coverage, which actually encourages them. So I think it's very, very important to take that into consideration when we're talking about community engagement. So coming to the issue of multi-sectoral collaboration, like I said earlier on, that is what we don't really know how to do much in the health sector. Forging collaboration, even intra-sectoral collaboration is difficult, not to talk of collaborating with others. But we have a few examples of successful multi-sectoral collaboration work. And I'll give an example of the multi-sectoral collaboration around National Action Plan on Health Security. All of us know health security is everybody's business. But I think giving it to the leadership of the NCDC then and now, I think they've been able to successfully identify sectors that are important, including finance, which is extremely important, the National Assembly, Ministry of Agriculture, National Nuclear Regulatory Agency, Office of the National Security Advisor. So to me, they've been able to come together, and all of them support the implementation of National Action Plan on Health Security. And one of the evidence of that performance is that during the joint annual review, the scoring, JE, Joint External Evaluation of Health Security, actually improved tremendously. I think it's around 60 something or thereabout from 30 something, which is what, which means Nigeria is better prepared to tackle health security. But what are the most important lessons from this multi-sectorial collaboration? Number one, clarity of role. So when we develop National Action Plan Health Security, it is quite well defined that this is what the Ministry of Health is going to do. This is what Port Health is supposed to do. This is what NRA is supposed to do. And there's a forum that brings them together. And more importantly, they ensure that these activities translate to the budget for each of the participating agencies. And they did not stop there. With the help of development partner, they are able to track these resources and hold them accountable that NRA, you in your budget, you are supposed to allot this. Port Health Authority, you are supposed to buy this screening machine and all those. Have you done it? And there's a strong collaboration. And again, more importantly, is the issue of leadership, because of course, it wasn't devoid of challenges as well. There were instances where other participating agencies thought NCDC was only interested in their own budget, they are not interested in that. But of course, there will also be conflict. But to me, that's a very good example. And that's actually translated to opportunity for better partnership with the private sector, because the public sector is able to arrange itself very well, coordinate itself. It was easier to create a PPP policy. Of course, the work is still ongoing, where private sector is identified, what are their roles and everything. And we saw it happen during COVID, where the private sector came in effectively to invest. Let me pause here for now. Thank you.
Okay, Dr. Gafar, I'm glad that you touched on some very sensitive things, and you did so extremely well in the public-private partnership, interministerial and multi-sectoral collaboration. In part of the question I asked, I talked about social protection. Now we have, I want us to be a bit practical. We have a coordinating Ministry of Health and Social Welfare. We have a Federal Ministry of Humanitarian Affairs and Poverty Reduction. Because if we would have to take out some of these challenges, we have to speak it the way it is. Now, vulnerable people could be found either ways. You have people who have been internally displaced, and then people who have formed, who were, let me say, have some humanitarian crisis. And I and my friend Abubakar Kurfi have always said that one moment you can be rich, the next moment you can be poor. For instance, if the whole of your house got burnt because of some current surge or voltage surge, and you have got everything in there, and probably it took you 30 years to build that house, it means you are one time sustainable, and then the next moment you are there. What do you think that the Federal Ministry of Humanitarian Affairs and Poverty Reduction and the Coordinating Ministry of Health and Social Welfare can do so we can take care of probably health coverage for internally displaced persons, the elderly, and the vulnerable population? Thank you.
Okay, thank you. Again, this is very, very interesting, and it speaks to one area of work where I was actually involved less than 2 years ago, when the then Minister of Humanitarian Affairs, came on board, Dr. Betta Edu. I think she called upon myself and a few other colleagues to see how do we have a robust multi-sectorial action plan on social protection. And what we actually did then was to do what is the mapping of humanitarian action, because what is the interface? So we discovered there is interface with health, there's interface social protection, there's the interface with housing and others. And then we design a multi-sectorial platform that will bring these actors together, including health insurance. Dr. Kurfi attended some of those meetings for the NHI. And we map out a clear coordination structure in terms of if I'm in a humanitarian situation today, or if I'm not, and it happens tomorrow, how do we ensure that I get good accommodation, I get food, I get health, I get water, I get even education during that humanitarian phase. So, unfortunately, there were issues, and then that focus and that vision did not actually, move very well. But there is a window of opportunity now, because under the current leadership of the minister, I think there is a renewed interest in terms of pushing it. So there is an interest in pushing domesticating humanitarian policy. We just domesticated that of Zamfara State, which state clearly what is the multi-sectorial arrangement, who does what, who bring what resources. But at the same time, we have to strengthen the coordination framework so that we have a common plan, and each ministry, department, and agency is able to allocate resources. We have a way of tracking, and at the same time to ensure people are doing what we are good to do. So I would say the good news is that we have policy direction, we have the institutional arrangement. We need to do more in terms of translating such policy to action. And secondly, what I would like to see, because now the Ministry of Health has moved from Ministry of Health to Ministry of Health and Social Welfare. The question we've been asking, what does that translate to, the social welfare aspect of the nomenclature of the Ministry of Health? And then we need to ask that question collectively. So to what extent is the Ministry of Health involved in engaging other sector? But again, I think the Ministry of Health is already translating it to action. So through the project called MAMI, which is geared towards crashing the maternal and child health in Nigeria. So if you look at the framework of MAMI, because we have all recognized that no matter what we do in the health sector, no matter what we do, we are not likely to crash maternal and child health except we get other people do their own bits. For example, those involved, and even in the road construction, you understand? No matter if there's no physical access from the village to the health facility, what should we do? In terms of energy, if the facility there is not a proper availability of energy, you know that health workers are not likely to be there at night. There are some sensitive, very important commodities you are not able to keep and all those stuff. I can see the framework of MAMI taking this into action. What I'm not sure of or yet to see is how we translate this into action. And all of us, we have a role to play in terms of engaging the relevant player to see these beautiful opportunities, because I was very excited when I see the MAMI framework, because it actually addresses some of those questions I will be asking around multi-sectorial collaboration. So I don't just want it to be on paper, I want it translated to action. Thank you.
Thank you so much, Dr. Gafar. So this is a clarion call that we need to revisit that policy wherever it is. So the coordinating Ministry of Health and Social Welfare and the Federal Ministry of Humanitarian Affairs and Poverty Reduction can work in concerted effort to help. Dr. Kurfi, are you there?
Yes.
Thank you very much. So we in the course of our discussion, we brought in the Basic Healthcare Provision Fund. And while I served as Director of Health Financing for the USAID Integrated Health Project in Nigeria, we have contributed significantly to building the BHCPF 2.0. And part of the recommendations that we made is the strengthening of the local government health authority for the purpose of governance. And then, of course, we encourage what we call participatory governance model, though we have the Work Development Committee in place. And of course, I want to specially thank Dr. Kelechi Ohiri, who have deliberately made some of these things performance-based. So those who misuse resources may not be part of the resources, in as much as it is 1% of the consolidated revenue fund. But of course, there's something that you spoke of, and I want you to probably shed more light on. how can Nigeria as a country institutionalize community participation, which we have termed it community level governance in health planning and oversight to improve service delivery and responsiveness, because this is an integral part of the governance process in health.
Okay, Dr. Fabong, please allow me before I answer this to go a little bit backward. There was a question, there was a very important observation Dr. Gafar mentioned, that is, where is the social welfare in the Ministry of Health, right? And so as important also, I want to clearly point out that that social welfare component of the Ministry of Health is actually anchored by the NHIS, by the NHIA, right? And so the social protection component of that work, bulk of that is taking place in the NHIA. And that's why the NHIA is deliberate about interventions like the CMONC, which I mentioned, which is the free cesarean section for pregnant women, that is taking place nationwide. And that's why the NHIA has also rolled out a social intervention like the free fistula program that provides comprehensive coverage of healthcare for people with VVF, which of course we know is a very debilitating social disease, and then also they enroll these people into health insurance. That's why the NHI is also deliberate about expanding the basic healthcare provision fund and reforming the BSCPF to be performance-based, as you mentioned, right? And that's so, but this performance-based, I just want to speak a little bit more to this. It's not just so even about the community level system that we're talking about. I think the issue of performance is critical, not only at the community level, but at all tiers of health system. If we don't hold each other accountable, if performance does not drive our decisions, we will still be back to where we are, whereby whatever we do is not strategic. And so we should be deliberate about encouraging performance, and also we reward and then we sanction. I think that's one area that really needs to come out clearly. I think the availability to enforce and to ensure that we are able to do that. So that's one thing I want to also highlight. On the issue of vulnerability, I also want to, maybe Gafar forgot, me and him actually have led a work in the NHIA currently, which is going to be disseminated tomorrow, about developing a vulnerability assessment and mapping tool. So this is, we have worked with all stakeholders working in the health insurance ecosystem to come up with a tool that will identify objectively who is vulnerable, and for enrollment into social health insurance interventions. And this tool is really leveraging on a lot of indices, the social register, community targeting mechanisms, and other, of course, disease and social indices in the community level. And so that is something that needs to come out, because a lot of efforts are being made to ensure that identifying who is vulnerable is actually objectively done. Now, lastly, on your question on community participation in health, I permit me with permission to make it community participation in health insurance, because the health space is very broad, and I don't want to speak to an area that I cannot say I am. So for health insurance, this is something that I've always personally made noise about, that the supply side of the equation, if you see a lot of, for example, CSOs working on malaria, CSO working on HIV, CSO working on TB, Aquamin for this, but you hardly ever see civil society organization working on health insurance. You hardly ever see community-driven organizations that are focused on encouraging the demand side. So apparently, I see the civil society space is afraid, or is has not really understood, this space. And I think that deliberate engagement needs to happen to ensure that we bring them into this space so that they can contribute their own quota in serving as accountability champions. That's one. And the second thing I also want to say, for this is also the basis of for community participation to really be effective. I think what you are providing should also be of high quality. So also health insurance should provide care that is qualitative, so that you can build that trust among community members, so that they can also serve as champions for you. Mind you, in health insurance, your enrollee is your best marketer. So if the community members are actually satisfied with what we provide, they can serve as champions for health insurance. But lastly, there is a factor that I really want to bring. That is the political economy factor that Gafar mentioned. Still, community members can, but leadership at the higher level is critical. It's critical to harnessing the voices of the people at the bottom and making sure that those voices count. Because if community level structures shout and nothing is done, if it demotivates. And so I think that's the system has to be deliberate about taking into consideration the voices of the poor and the marginalized and making use of them. Thank you very much.
Thank you, Dr. Kurfi. That's very elaborate, and I've been following. So apparently, we have a low-hanging fruit, and we could use part of what we envisage at the end of this webinar is to provide solution. And today I'm enlightened that the social welfare component of the coordinating Ministry of Health and Social Welfare is actually handled by the NHIA. So you see, this is one of the solutions, and then it is good that we have this information so we can go forward. Dr. Gafar, part of what Nextier is doing is creating innovative health financing so that our people can access quality and affordable care in rural and peri-urban areas. And of course, the initiative by Nextier is called the Frontier Clinics. So Nextier intend to enter into public-private partnership so we could take up these primary healthcare centers and then try as much as possible to renovate them, setting telemedicine and other facilities, and then people still get quality services. By the way, Nigerians will always find a way to pay for healthcare, so long as they are sure these services will be of sufficient quality. So we are about to start a pilot, and then we intend to share some of these amazing stories and report. So being someone who is in the private sector, what other innovative models of public-private partnership that can expand health access and coverage for underserved populations? Thank you.
Okay, thank you very much. I think before I go to that answering that specific question of innovative PPP approach, let me build on what and try to interrogate some of the conversations so far. So Kurfi talk about the social welfare component of the Ministry of Health being handled by NHI. That's true, but I think that is not the full story. So and then we have to be on the same page regards to that nomenclature, social welfare. I think there are two components to it. Number one component is social protection, which Kofi is talking about, looking at social protection. But again, social protection has been part of the health all this while. But to me, what is new is addressing the social determinants of health. And if you look at the nomenclature, and the nomenclature of the Honorable Minister is the coordinating Minister of Health and Social Welfare. You understand? I think the last time I checked, there are only two coordinating ministers. So, and there is a coordinating Minister of Economy, which is the Minister of Finance. I think the thinking now is that if you look at the whole, the whole space, you can divide into maybe social and economy, and then you have somebody to coordinate the social part, as another minister to coordinate the economy. Though there's a huge overlap between social and economy because health is a huge contributor to the economy. In fact, there's a concept of health economy now, not economics, health economy. Now, so that if social protection is being handled by Ministry of Health Insurance, the NHI, who is addressing the social determinants of health? I think there's still a lacuna there that we really need to address in terms of how do we bring different elements, how do we work with education, how do we work with water resources and many other sectors that play very, very important role. Let me remind you, when the MDG, after the MDG era, when the MDG evaluation was done, they discovered that the progress made during the MDG era in terms of reduction of maternal and child health, half of the reduction was only attributable to the health sector. The other half of the death reduction was attributed to sector outside the health sector. So we cannot just be saying that, okay, we're handling the social protection bit of it. We have to look at, and we need a serious conversation around the social determinant of health. So there are some things, for example, if a woman is educated, there are some things you don't really need to worry about much, whether she wants to attend antenatal, deliver in health facility. Those are the things we are still grappling with in terms of sensitizing women to be delivered. Just get them education, and education will help you do that. Get water to be working very well. Half of your diarrhea situation, which kill a large percentage of children, is not. So I think that's that area we are not yet addressing in the health sector. We need to look at. So there's the issue of civil society organization. I believe that the civil society organization, when it comes to accountability, even the basic care provision for, let me use the example of Nigerian USC Forum. Nigerian USC Forum has developed a robust and work with the health sector reform coalition accountability framework of basic care provision fund. It took us 2 years to develop it, which look at from community to facility to state or federal level, what indicator to track, what you do, and all those stuff like that. Very, very robust. I think it is necessary to put this thing into action. We're having discussion with Ministry of Oversight Committee Secretariat on how to put this. So I think there are civil society that really understand what is happening. I think we just need to do more work to translate all those framework to action. So you ask a question around innovative public-private partnership approach. To me, let's try as much as possible to look at what is on ground, what is working. So that's what this private sector health alliance is actually doing, which they call adopt one facility in the local government. And they've started in a couple of states where they will go there and they will deploy full spectrum of support from both the supply side and demand side in terms of innovation, in terms of an innovative way of paying for health workers, in terms of buying health insurance for the people, because part of the lessons we have learned over time, anything that we do for the poor people in terms of providing facility and everything, if we don't take care of the social protection in terms of buying health insurance for them, it's not likely to work. So here, there is an opportunity for testing a view innovation around telemedicine. There are a number of groups that have deployed resources. They have learned lessons in terms of what work, in terms of telemedicine, connecting, even teaching hospital, other government hospitals to rural areas where it can work. I think there are a number of e-health innovation that have been there. But I think whatever we do, we have to look at both the supply side and the demand side, and then whatever innovation that we are going to bring, it starts to be a context appropriate. But at the same time, that innovation you are talking about is an opportunity for you to test a number of things that we know that works, but probably the government institution probably don't have the technical bandwidth to put them in action. Things like, for example, things like biometric attendance we are talking about in terms of addressing the issue of absenteeism, things like ensuring that use of data for decision making is well, enshrined in the processes. Things around creative way, mind my word, creative way of engaging the community. Because like I told you, it's not all community engagement process that actually work. There are some community engagement structure that are more problem than solutions as well. So we just have to be as creative as possible. And again, part of the advice I actually gave you people is that you should have a learning agenda in terms of, okay, these are known, but these are known unknown. So let's try them in this facility and try as much as possible to learn lesson over time and ensure that our government is heavily involved, because for sustainability, Whatever you learn, whatever you do, if you are not involved, you just finish, you do your dissemination, people will clap for you, this is what you've achieved, and nothing will be sustained. I think those are some of my suggestions for the innovation you are talking about. Over.
Fantastic. What an interesting discussion. It reminds me, yesterday I was in Lafia and we were talking engagement, and one of my colleagues said some of those engagement is just walima, where people just come, eat food, and just disappear or cause more problems. You just alluded to that fact, Dr. Gafar. To our amiable participants, kindly drop your questions in the chat box. Dr. Gafar and Dr. Kurfi, it's been an amazing time with you, but we have a couple of questions that has been asked here in our chat box. Part of this is, I think, let me start with a contribution. Professor Jonathan Dagwell said the issue of lopsidedness in human resources for health in favor of non-technical is real. However, in converting non-technical to clinical staff, care must be taken to properly train and monitor them so that they do not cause more harm or problems to the field. And Daniel Minor said, he said, okay, this one is a question actually to Dr. Kurfi. He said, why have we not been able to widen the enrollment net for health insurance? So Dr. Kurfi, can you answer that?
Okay, so thank you so much, Dr. Fabong. I will answer that, but please allow me to revisit an issue that Dr. Gafar just discussed.
Briefly, very briefly.
Yeah, briefly. So, Dr. Gafar, I think the concept of social protection and social welfare are two sides of a coin. Thank God all of us are speaking from the same space. But to my own understanding, social protection is the broader umbrella. Is that umbrella that talks about all those policies and programs that you need to put in place to safeguard individuals. While social welfare refers to those providing assistance to those in need, especially those in low income thresholds. And so my thinking is that social protection is subsumed, social welfare is subsumed under social protection. And so that's just for emphasis sake. And but the back to the issue of question for Daniel Minor that says about why have Nigerians not been enrolled into health insurance. I would say, first of all, let me first of all say.
Okay, Dr. Kurfi, he actually asked two questions. He said, who is responsible for enrollment of persons into health insurance program, and why have we not been able to widen enrollment for health insurance?
Okay, so I think first of all, the responsibility for health insurance enrollment. So you can actually, Nigeria is one of the countries that have multiple avenues where you can enroll to enter health insurance. You can walk to the NHIA and get enrolled into health insurance. If you can afford, you can buy a private plan from a HMO and get enrolled into health insurance. And there are 36 plus 1 state social health insurance agencies where you can also enroll. So the avenues for where to get enrolled into health insurance are enormous. I can say we have the highest avenues for any country, where you can, so that is not even a problem. The most important issue, I think, is why have we not been able to accelerate the progress to health insurance as health insurance is concerned. And I would say, first of all, I think we should appreciate the fact that serious progress has been made. I was looking at the question and answer chat, and somebody asked how many, that it was a comment, how many Nigerians are actually covered with health insurance. So as of today, I can tell you there are 20 million and 2,082 Nigerians covered with health insurance. This figure is on the NHIA website. So it's not something that is hidden, it's available. This is the first time that the population of Nigerians covered with health insurance is aggregated across all types of health insurance and displayed on the NHIA website. This will give also credit to the DG of the NHIA, Dr. Kelechi Ohiri, because this is the first time that we are seeing this. So it's regularly updated on a quarterly basis. So by next quarter, the progress of this enrollment will also be shown. And you can see the remarkable achievements in the number of Nigerians that have been covered over time. So then, I can tell you we are making progress in covering Nigerians' health insurance. But whether that progress is good enough is a question that we need to ask ourselves. I think we can do better, right? And I would say a lot of factors come into consideration in this. Key among them, I think, is perception of Nigerians on what health insurance is. Awareness is also a factor. Then the space also, is also a very important variable here. Quality of care that is provided sometimes can serve as a demotivator for people to access health insurance, among other factors. But what I can tell you that all these stakeholders that I mentioned, they are doing all their own bit to ensure that they enroll Nigerians into health insurance. Thank you.
Thank you, Dr. Kurfi. This question is from Monte and McMulchy. And he said, he talked of the question of corruption within the state must be curtailed as much friction exists, resulting in less funding for education and healthcare, or both if necessary. He said, how can the Nigerian tax system be recalibrated, ensuring all citizens and corporate entities remit to the state equity fund? That's what it means. So either Gafar or Kurfi can answer this.
I think if it's tax, take it to Gafar. He's the specialist in tax.
Dr. Gafar.
Okay. But to start with, an interesting question. I just made a presentation this morning where we look at Nigerian government spending as a proportion of the GDP, which the data that we have, the most recent one shows that Nigerian government is spending less than 1% of the GDP on health. And then, is that good or bad? Puts it side by side the benchmark. The benchmark is around 5% of the GDP, that the government should spend 5% of GDP if we want to make progress towards universal coverage. But we have to understand the Nigerian context. Before now, say like 4 years ago or thereabouts, Nigeria tax to GDP ratio is one of the lowest in the world, around 6% then. So if government collects 6% as tax, and you want government to spend 5% on health, that's not going to happen, because there are other sectors and everything. But answering the question, I think there's a window of opportunity. So the last time I checked, from 6%, Nigerian tax to GDP ratio, and from the tax collector office, they are telling us around 13%. That means a lot of things are happening in terms of tax reform. And don't forget, now there is even a new set of fiscal policy that is looking at tax administration. So what is likely to happen? Government is likely to collect more taxes, looking at where there are loopholes and everything. I hope the tax burden is not going to, in such a way, that tax burden is not going to be heavy on the people. So this is a huge opportunity. If government and the Nigerian government, I think they are targeting higher tax to GDP ratio, even beyond what we have now. So there's a huge opportunity. What we need to do is to engage effectively, and then engage the government and say, now you are not collecting enough tax before. That is why health was being underfunded. Now you are collecting more money. And that is not enough. We must be able to make an economic case for health. There's a Lancet publication that just came out that shows that health is contributing 7% of Nigerian GDP. It is almost 9% in the UK, and it is 10% in India. So we have to make a case that we are contributing very well to the economy, because before this data came, the chief at the National Planning Commission used to tell us that you have to provide evidence that health actually contributing to the economy. So we have the evidence now. So we really need to make a case around health economy, as in how health is contributing to the economy, make this case for improved allocation. Improved allocation alone is not enough. We have to demonstrate that we are efficient, because the Ministry of Finance, ECS sector, as a group of people that are not very efficient, they just like collecting money. They don't like telling us what the money is mine. I think all those narratives just have to change. Thank you.
Thank you, Dr. Gafar. Our time is well spent. Dr. Kurfi, maybe in a minute or so, Sesu Akume said too many reporting templates for data, NHIA, NDA, CDA, HIMIS, which are all under the Federal Ministry of Health and Social Welfare. They can easily harmonize along with development partners. Why hasn't this been done?
Well, I was just telling him that I'll answer this on a positive note. I think something is being done in that direction. And in fact, the Federal Ministry of Health is working towards rolling out a very comprehensive ICT-driven health management information across all the stakeholders. So something is being done along that dimension, yeah.
Oh, thank you so much. Chukudi Onyeachu said it's a known fact that universal health coverage, health insurance coverage has not been met in Nigeria. And what is the roadmap to achieving this in Nigeria, most importantly for the underrepresented?
So the roadmap is clear. The NHIA has worked with all the stakeholders to develop a 10-year strategic plan, which has been reviewed into a 5-year strategic plan with the coming of this new DG. And this plan has mapped out trajectories for coverage of health insurance across all dimensions with health insurance. And the DG has also asked that we break down this plan into an annual operational plan, and this we did during the last management retreat. So I think the country has a roadmap and is aggressively working to ensure that we meet that roadmap.
Yeah, so hang in there, Dr. Kurfi. Suleiman Mustafa said the suggestion on CSO's involvement on the health insurance space will be one game changer in expanding coverage. Can the national government intensify efforts in enforcing the mandatory health insurance?
Yes, so the government is making efforts in enforcing mandatory health insurance. And very soon you hear some very strategic, moves. I don't want to preempt, but you hear a lot of, very soon, I mean very soon, some very game-changing moves will come regarding mandatory health insurance.
All right. So Muhammad Isa Jafar also asked you, he said, Dr. Kurfi, given the youth comprise more than 70% of Nigeria's population and often champion accountability and good health practice when meaningfully engaged, how is the NHIA involving young people to promote social health insurance uptake?
So I think this question is extremely important. And I think the youths are the backbone of any health insurance scheme, because we operate a system that is anchored on risk pooling. So we want more and more youths to join into the health insurance space. And I would say that the avenues are open actually across all our state offices, across all the state social health insurance agencies, and across all the HMOs. So actually, we work with the youths to ensure that they are meaningfully engaged in the health insurance space, and they contribute to ensuring that Nigerians achieve universal health coverage.
Thank you. Dr. Gafar, Nana Joyce Ndam said, how do you propose strengthening integration between donors and the government to leverage those resources by donors and provide access to health to the vulnerable population in Nigeria?
Okay, I think what is very, very central is the issue of coordination. And the one we say coordination, it has to be led by government. Government has to be very, very clear in terms of these are the priorities and everything. Have a very strong coordination framework and ensure that the planning and investment of donor actually align it. I think one example we have seen the sector-wide approach, which is geared towards in coordinating the space to ensure everybody there's one plan, one implementation arrangement, one financing, one voice as a son. Of course, we have to do more to ensure that that really, really translates to action, to ensure that at the national level, because the framework is very, very good in terms of, okay, this is the set of priorities. But at the same time, this is how donors are coming together and all those. So, but we need to do more. Of course, it's a very good visionary initiative from the Honorable Coordinating Minister. But I think there are still gaps at the subnational level, because In recent time, we interacted with several states to look at what is happening in terms of effective coordination, bringing, Ministry of Health people are still complaining they don't know what the partners are doing and all those stuff like that. I think we need leadership there. We need coordination. We need effective institutional capacity to be able to manage multiple donors and say, these are priority. This is where you are putting money and it to be tracked. And then there should be mutual accountability. It's not only partner that should be accountable to the donor or the other way around, because we have seen instances where it is a lot easier to get funding record of government than getting that of partners, which is supposed to be building the capacity of government. I think so. Those are the things we have to look at and do things differently. Over.
Thank you, Dr. Gafar. So Micah said, will there be recommendations of the feedback received from participants that could support organization in the future? Absolutely correct. This webinar is not just one of those webinars where we just talk and go, which is why we are bringing the people who are active participants, and we intend to harmonize this and share in a policy document and to strategically take this information to the people who should utilize and also participate in the implementation of some of these recommendations. And that could also answer Beatrice, who said she joined in late. And if she could have a recording, usually we send the links to all the emails that have participated in today's program, so they can do a follow-up. Chris Azo said fraternal greetings to all partners. He's the chairman of Anambra Civil Society Network. And then he asked a question. He said, what is the level of civil society organizations partnership in this enormous work that we do? I just want to let you know that we have a large pool of civil society organizations, and now that you've participated and have indicated interest to work with Nextier, you dropped your phone number and email address, we will get to you so we can talk and see how we can move this country forward. Briefly, Dr. Kurfi, one last question is from Kechuku, who said, the question is for all panelists, but I think you are in the best place to answer this, that the drugs that are on the list are not in most cases given to patients. So what do you do? Also, the hospital change drugs frequently. So how do you tackle stockout syndrome?
So I think I would say there are two dimensions to this, right? There is the hospital, three dimensions. There is the hospital angle, there is the regulator angle, and there is the patient angle. And I'll start with the patient angle. One of the key things we encourage is that if you go to a hospital and you feel you are shortchanged, please complain. Complain help us to improve. Complaints help us to make sure that these kind of things don't happen again. And so we have lines, call center lines in all hospitals. And I'm speaking this even for all the state social health insurance agencies and even for the HMOs. They all have contacts, they have call lines that you can reach them. And because of this, we ensure that both the shares and the HMOs and the NHI all have 24 hours call center. So it's not a call center that closes. So if you are not happy, please call so that we handle those complaints. And then for the facilities, we have also understood this challenge, and the NHIA has reviewed the tariff that it pays those, because most of the complaints is that the payment NHIA is paying is not enough. That is why the NHIA deliberately reviewed this tariff and increased it to about 600% increment in the fee for service, just trying to ensure that we accommodate existing realities in terms of inflation and economic hardships, to ensure that facilities provide a quality healthcare for our enrollees. So I think with this issue of tariff, no facility should complain to us that he has no, she has out of stock. And I know the state health insurance agencies and the state health insurance agencies and the HMOs who have also are making effort to leverage on this increment in tariff to review their own tariffs. And on the final note, I would say that the NHI has also brought out a policy of 1 hour maximum delay for referral. So if you go to a hospital and you are not treated, you need a referral and you are not giving a referral code within 1 hour, NHIA mandates that you flag this up, and the NHIA has also monitored our state offices that we should intervene and pay, and the HMO will be made to pay. So this is a game changer as far as service delivery is concerned. Thank you.
So thank you so much, Dr. Gafar Alawode and Dr. Abubakar Kurfi, for the sacrifice of your time and sharing your wealth of experience and knowledge with us. Special thanks to the participants who have actively participated into this Universal Health Coverage Dialogue Series. We would get back to the stakeholders and the participants with our policy statements and ensure that no one is left behind in the business of strengthening health governance, fostering collaboration, and ensuring accountability. Until now, do have a great day. Thank you.